Let's move on to the macrolide antibiotics. These macrolide antibiotics are a very important group of medications because we use them all the time, especially in respiratory infections. Now, these agents are blocking the 50S unit from transcription. Important agents include erythromycin and clarithromycin. They're rapidly eliminated from the body. They're considered broad-spectrum antibiotics, and as I said before, they're most commonly used in respiratory infections. Azithromycin concentrates into macrophages and other tissues, and it is actually eliminated quite slowly. This particular medication is also effective in gonorrhea. The nice thing about azithromycin is that you can actually give it as a 3-day set of medications, but it lasts for 10 days. So the killing activity actually lasts much longer than the drug is actually in the body. Other medications are more narrow spectrum within this drug group. The selectivity targets are generally gram-positive anaerobes and aerobes, and these are used often in Clostridium difficile infections. Let's talk about the resistance to macrolide antibiotics. It's actually quite an interesting topic because of the mechanisms and the resistance patterns. Now, you actually will develop ejector pump mechanisms in some bacteria that literally pump out the drug, the active drug, out of the cell. It's quite an interesting phenomenon. The other thing that may happen in resistance patterns is changing the binding site of the macrolide by perhaps adding a methyl group. Now, the problem here is that there's a 100% cross-resistance pattern between one macrolide and another. So if, for example, you give a patient clarithromycin for a respiratory infection on week 1, they come back with resistance and you decide to try a different medication, there's going to be cross-resistance between those two, say between clarithromycin and azithromycin. There's partial cross-resistance with drugs like clindamycin and the streptogramins as well. And there's resistance in the Enterobacteriaceae species. And that is due to the production of drug-destroying esterases, not because of the ejector pump. So it's a slightly different mechanism, but still 100% cross-resistant pattern. Let's move on to the ketolides. Now, the ketolides are structurally similar to the macrolides, and I haven't put a separate triangle here. Let's just say that that triangle is both for K and M. It has the same mechanism of action and the same antibiotic spectrum as the macrolides as well. Now, a lot of times macrolide-resistant strains are susceptible to the ketolides, and there's an increased affinity to the ribosomes with the ketolides than with the macrolides. They are also poorly ejected through ejector pores, which is why we think these may be a really good choice for some people. So they sound very similar to the macrolides. They're used in community-acquired pneumonia. They're nice because they're given once a day and they're oral medications. Downside, they can act through cytochrome 3A4, and they do prolong the QT interval on the ECG, which potentially could mean that they could be proarrhythmic.